Okay, good morning, everyone. It's Paresh here. I think we'll make a start. Welcome to this second part B of Stream 3, Population Health and Digital Literacy. The High Performing Primary Care series brought to you by North Queensland PHN. We'll perhaps just move on to the next slide and just an acknowledgement to country to begin with. And we acknowledge the Aboriginal and Torres Strait Islander peoples as the traditional owners of the lands and pay our respects to their culture, their people, and elders past, present, and future. So I'm Paresh. I won't go through the intro, introduce myself last time, and delighted that Ange been able to join us today. And you got Ange's sort of bio and background there, so we won't sort of go into the depths of that. And we'll just move on to the next slide. So as you all know, the whole series, the High Performing Primary Care series, brought to you by the PHN's got 4 components to it. There's continuous quality improvement and PIP component. There's the accreditation and the 5th standards component. There's population health and digital literacy, and then there's integrated care. And so we're actually looking at that 3rd stream, the population health and digital literacy stream. And so when we're thinking about this, the whole series, the 4 components coming together, what we've got here is really a comprehensive suite of material, education, training, that's really focused on, I think we all do a great job in primary care and general practice, but it's how can we build on that great job we do. And it's, in some ways I kind of think about it as it's going from good to great, and how do we do that? And so the way really is around building our capacity and capability to be able to put contemporary thinking into our practices, all really being driven to achieve what we talk about as a quadruple aim. This isn't something that happens overnight. It's a gradual process, and so that culture of continuous quality improvement is almost critical to it. These things require effort, time, resources, and so it's really important that we join up any existing initiatives that are out there. So we're not all sort of working harder and harder, but we're aligning things and working smarter and leveraging off those existing initiatives. There's no doubt in my mind technology is going to form a growing part of how we deliver primary care. And so that digital literacy and the use of data to support what we do and how we do it, again, is just so fundamental to high-performing primary care. If we do these things and build them into the DNA of how we run our practices, then we can actually be sustainable in implementing these initiatives. And ultimately, this isn't a Lone Ranger game, so we can't do it as individual clinicians. We certainly can't do it as individual practices. We're part of an ecosystem that's really got to come together and work together around that shared purpose, which is delivering better care for patients. And so integrated care in the region is almost fundamental to this. So if we move on to the next slide, just some signposting for you around, as per last week's webinar. Today's webinar is again interactive. There'll be online polls for you to do as we go through different parts of the presentation. We're also using an online whiteboard, but we'll kind of manage the whiteboard our end. So you might just see us flicking between different screens and a little time lag as we flick across. Apologies for that. Really grateful for the PHN staff today, so supporting the webinar with doing some demos of PenCat, because how we use PenCat and the data that's in there to help support how we deliver care, it's really important. That's sort of, approach to population health based on data and making intelligent use of that data is really important. And so using technology to support that, and then having the demos from the PHN staff will just make it so much more real than us talking in abstract terms. So thank you for that. In your workbooks, and again, as per last week, there'll be a lot of stuff we're talking about, what the what. What I'd urge you to do is, as we talk about the what, is think about so what. So what does it mean for you in your context, in your practice? Because until you do that and sort of reflect on your context and the so what for you, you can't really then translate it into action, which is where the next step comes, the now what. This is the actionable stuff you can do as a result of the learning from these webinars. So really strongly encourage you to think about this reflective template, what, so what, now what. Perhaps capture things as we're going along around the what, and then that can be your framework, if you like, to sort of come back to later and reflect on the so what and now what. So we talked about the 4 components of the higher performing series earlier. Each one of those components is divided into 3 subcomponents. And so when we're looking at this one on digital literacy and population health, the 3 subcomponents were our introduction, which we did last week. Today, we're really looking at intelligent information management. And then how do we use that intelligent information management to convert into a care delivery system that works for everyone? And that's what we'll talk about next week. But today's focus is on intelligent information management. So in the introductory session last week, I'm just going to do a really brief recap just to remind ourselves, because amazingly, a week sometimes feels like a long time ago because so much happens in between. So some of the key things we talked about last week were, population management is about moving from the reactive to the proactive. And in doing so, we're kind of improving patient experience and health outcomes. So today is really around how we use data to help us become more proactive. And then we last week also talked about the 4 habits of high-performing healthcare organizations. And so we talked about specification and planning, having clear directions and instructions around what happens when for which subpopulations, which then allows us to design that sort of clinical microsystem, the infrastructure design around how we actually deliver care. We'll do a bit more of that infrastructure design stuff next week. The final 2 habits, I think, are really important. And that's where, some of the data stuff, which we talk about today, come in. So, how are we doing? It's really about having a learning system. That learning system is shaped by a whole bunch of indicators. So understanding what indicators we can get from our clinical system, how we're performing against those indicators, asking meaningful questions of how we're performing, and then converting that sort of insight into sort of reflection, self-study, and then improvement. Are the other 2 habits of high-value organizations. We talked about the population health pyramid last week. So we talked about how we can actually stratify our population into meaningful subgroups. And one way of doing it is using a population health pyramid like this. This one comes from Kaiser Permanente in the US. And it sort of says, the majority of our population is about health promotion and disease prevention. A smaller number of that population, might have single condition type of diseases. They're generally pretty well. if we can help them to better look after themselves, so supported self-care, we will be doing a good job. As we go up the pyramid, the complexity is increasing. So, here we might start to have people, with multimorbidity, and then right at the top, we perhaps get the, people with complex and chronic conditions, where social situations may also be impacting on their health. And so what we're really doing is doing a needs-based stratification of our population, because once we've done that, we can do the things on the right-hand side. The things we can do on the right-hand side are, things like conducting health assessments, patient education and goal setting as we're moving up the pyramid, getting a bigger team involved by connecting patients in with the healthcare neighborhood and other providers, and then actually helping them coordinate and connect that up. And then, for the super complex, actually almost case managing them and having lots of touch points with the rest of the team through case conferencing. These are all enablers we have within the MBS schedule at the moment, which we perhaps could be using more and optimizing to deliver population health. We talked about a model of care, the chronic care model, of how we can do this. This slide's got a lot of information on it, and I'm not going to go over all of it. Again, the important bit is if you look at the bottom of the slide on the left-hand side, to get those population health outcomes, be they clinical outcomes or functional outcomes, we actually need a partnership approach. We need a partnership approach which includes an informed, activated patient sitting within an activated community, and that patient having a productive and interactive relationship with a prepared, proactive practice team, sitting as a healthcare provider within a healthcare neighborhood where there's partners that can be drawn upon. So it's that interaction that really drives the outcomes. And then the box at the top is really the components that kind of come together. Again, some of that we'll touch on today, for example, clinical information systems and how we use those to get the data. But some of that we actually come back to next week, because that's how you design the clinical microsystem to work better for us. And we finally talked about the 10 building blocks of high-performing care, and you can see population health management sits in that second tier, surrounded by a number of building blocks which are around data-driven improvement, enrollment, patient registration, empanelment. It's a sort of term we'll sort of use to describe that a bit later on today, so we'll talk about that. Team-based care, a partnership with the patient, all important aspects that we need in place so we can actually do population management.
When we talk about person-centered medical home model as such, these are instrumental in the foundations for high-performing primary health care. So we need to get this right at the foundational level to enable us to implement the other aspects of the 10 building blocks here.
So, if we look at the three parts, part A, B, and C of this population health and digital literacy series, we've got the learning outcomes up here. And so the two at the top, which are sort of grayed out, we did last week. We started on demonstrating an approach to understanding your population, and we build on that today. And today we do a lot of this data extraction around predefined populations and asking meaningful questions of that data to then help us create an action plan to redesign care delivery, which we touch on next week. So today it's really about the third dot point and the fourth dot point there. And so if we look at that in more detail, what we're really going to do today is zone in on how we use our digital systems to support population health, how we ask meaningful questions of our data, and how do we interrogate the database, the clinical system, to give us some of those answers to the meaningful questions we're asking. So I'm just going to pause there, and maybe we'll just see if everyone's okay and on the same page. Has anyone got anything they'd like clarification on at this stage?
Feel free to take yourself off mute, or alternatively add something to the chat box.
And perhaps as people are thinking about that, we'll also start our first poll. So what we would really like you to do is use your phones. If you've got another device, a tablet or a phone, if you can point it to the QR code, and what should happen is a survey, an online survey should open up, which is asking the question, all the different subpopulations you currently actively divide your practice population into. So what we're really interested in is what you're actually doing rather than what you could be doing. So, if you're actively looking at your diabetic population, pop that in. If you're actively looking at people with osteoporosis, pop that in. But if it's something you could do, but you're not actively doing, leave that out. If you haven't got another phone or tablet device and you need to use your computer, then you can go to the URL, which is on the screen there and also has been typed into the chat box. So you can click on it in the chat box and it'll just take you over there. And we're just going to flick our screen to bring the poll, and give us a second. Okay, great. So we've got somebody putting immunizations in there. MBS utilization data. So we've got a whole combination of things around indigenous population, diabetes, people with polypharmacy, so you can do home meds reviews on them, and chronic disease planning. Great. Okay, so got mental health with a potential diagnosis, but not actually diagnosed or coded. So I'm just trying to, so whoever put in patient I can handle seemingly successfully, those are hard to handle and need to improve on handling better. Just wondering, I'm not sure who put that in.
Yeah, can you hear me? It's Dr. Arma Sultan. Can you hear me?
Hi, yes, Arma.
I'm the one who put that. It's two groups, patient I can handle seemingly successfully. Those who at the end of the consultation, I feel I could have done a better job. Specifically, I'm talking about people with borderline personality type B and those who want prescription medicine with addiction and stuff like that. These are still a challenge. So these are the two group of patients I handle. That's all.
Okay, great. And Arma, do you how do you are you sort of actively identifying them through using a database search, or are you sort of keeping a personal list of those, or is it more a case-by-case reflection as you see these patients?
Case-by-case reflection. I haven't done a registry yet, but that would be helpful. After this, we'll try to find a way to do it.
All right, great, thank you.
So in that regard then, Ahmed, do you keep a register of your patients with addiction and a register for mental health patients in those, as you mentioned, with borderline personality disorder?
Not just addiction. It's, for example, also a patient who comes and tell you they want this test and they don't. They take the GB as someone who's an obstacle in their way to have a proper care because they know better than the doctor. something like that. So rather than reacting to that, I'll try to help them by finding, okay, how do I handle that? So it's two ones, the one who come and want antibiotic or specifically addiction medicine, and they insist other doctors give them that, or people who, for example, come and want investigation because their naturopath did that to them and they just come here for the paper, something like that. So it's a very simple too. Those whom I seems to be convincing very well how to handle and steer into the proper health. Those who already get ideas that they know better, put it that way.
Okay, and look, Ahmed, thank you for that, because that's a really great segue into the next slide. So we'll just jump across to the next slide. Next one, Ange. Thanks. So I guess when we're putting a population health lens on, we're really thinking about a high level process, right? And in this high level process, what we really want to be doing is grouping people with similar care needs together. So Arma, in the example you were giving, perhaps there's two subgroups there. You've got patients who feel they've got a particular issue and they know what they want. And I think you identified some of them will sort of will be receptive to what you say and things, and others won't. So the question we would ask from a population health perspective is, how do you group them? How do you identify them and group them so you can actually design a care system that's different for them? So just maybe hold on to that thought, because once you've been able to group them into meaningful subgroups, you can then go to the next step, which is, for this meaningful subgroup, what's the best way of providing care? What does the evidence tell us is the best way for providing care for this population? And actually, when we think about that, we may come up with all sorts of answers, which may take us away from, actually doing it one-to-one may not be the right thing for these people. Maybe it's a team-based approach. Maybe they need to come and see a psychologist first. I don't know. I'm just kind of throwing out the concept there, or not throwing up the concept that if we think about our populations and what the needs might be, we can then start to think about how do we best provide care for them and look at the evidence for that. Once we've kind of done that, we can then say, how do we best measure whether we're hitting the mark in terms of providing care for them? So again, Alma, if we go to the populations you were describing, what are the indicators of care that you could use for that population? I kind of sense there were two things there. There's things about the patient, but there's things about how you as a clinician feel as well in looking after these patients. So can we actually capture both components of the data? And then once we've got those indicators and those metrics in place, we can then monitor them and track them and identify how we're doing to really create opportunities for further improvement and further refinement. So that's really the high level process. That's what we're trying to achieve with population health. And having a register, having registries is probably the first critical step. So if we're going to identify people into meaningful groups, we need to sort of have a register of those groups, and that register needs to be as accurate as possible. And we need to make sure we have processes that continue to keep it as accurate as possible. There's various ways we can do that. We can start off by looking at a prevalence search, right? So how do we measure up for the prevalence of our patients with diabetes compared to other practices in the region, compared to other practices in the country? If our prevalence is really low, or if our prevalence is really high, is that because we're not recording things correctly, or is that because that's what our population is? And so using data and doing what I call housekeeping searches can help us keep that register tidy, keep that register accurate, which is almost a critical success factor in providing good population health. Because unless you know who you're working with and you've got them divided into your meaningful subpopulations, you can't really do the next bit, which is provide, evidence-based care for them in a structured, systematic way, and sort of design a clinical delivery system to support you in doing that.
Yeah. So in that regard, Paresh, when we talked about the 10 building blocks, and data management was one of the foundational component, a foundational component of that building block is quality data. So without the quality data, we cannot then move towards population health management approach, which is why it's so critical in this agenda.
Okay. So that then begs the question, and this is where we'll do our second poll, is if registers are so important and such a critical success factor, do we have policies in our practices to try and get consistent coding of data, so we can maintain registers that are accurate? So this is where I ask you to again go on to the QR code, and we'll do the second poll. And what we'll do is, if you give us a moment, we'll just flick the question on the poll over to, yeah, so that's fine. So you should be seeing, okay. So this is really just a yes or no question. So what we'd really like you to do is just answer, do you have a clinical coding policy and procedure in your practice?
And remember, the link is available in the chat box. So you may actually need to refresh that link.
Great, so we've got a couple of votes and we're kind of pretty evenly split at the moment. Encourage everyone to sort of vote in this. It'd be really good to get a bit of a barometer of where practices are with respect to this. If I could maybe ask the person who said yes there, are you able to describe your policy, your coding policy? What does that look like?
Well, it's in the coding policy aligns with our medical software, which is medical director. So the coding is part of the consultation process. But I was going to put, but I could only put yes or no. As long as the clinicians are able to free text in the medical software, there's always this little margin of where you may not get the coding correctly, because they can free text as well, and that is not captured in our data program. So that's where we say, well, okay, we'll have to work on that and make sure. And I wish medical software would not allow a free text button, or even a text button for recalls, for instance, where you can just put in your own little recall reason and create a list of maybe thousands of reasons for diagnosis. But the yes button, yes, we do have the coding policy, which is part, like I say, of our medical software, and ongoing training that the doctors do use that one, very mindful to code and to add to medical history as well of patients to make sure that we are on the right track. Yeah. Which again goes over then to my health record. You have to make sure that you have the correct details and patient diagnosis in my health record. So it's like I say, it's always work in progress. So we can always do better, but I think we're doing good.
Good. All right. And can I just ask, in your coding policy, do you have sort of guidance for your team around what constitutes a significant diagnosis and what constitutes perhaps a non-significant diagnosis? what constitutes an active problem and what constitutes an inactive problem. Do you, what are the top sort of 20 things we really want to be working on and making sure we got the coding right on? Do you have that sort of detail in your coding policy?
We do that with our orientation, but that is part of the clinic orientation that I'm not part of.
Okay.
But when you doctors join our team, the doctors that are mentoring them ensure that they are on our coding policy.
All right, that's great. Okay, that's good to hear. Okay, let's maybe. Sorry, was someone going to say something there?
Suzanne, were you going to say something to add to that?
No, I just said thank you.
Thank you.
Yeah, no, thank you. Thank you for sharing. That's good. It's good to see that.
I think one of the learnings from that was around the fact that in terms of the fields within the clinical software system, is the fields are important, and having that understanding in terms of why they're important, I think is critical to success. So everyone sort of buys into what we're trying to do.
So, here's some meaningful questions we can ask, right? How accurate is our register? And the way we can answer that question is to say, all right, let's look at some of the common chronic conditions. How does our prevalence compare with others and the expected prevalence for that condition? So, in this example we've got on the screen, the gray box is the practice, and then you've got percentages for the PHN, and then you've got the national prevalence rate, and so you can kind of look at that, and I guess the question I ask myself is, okay, hypertension, if this were my practice, I'd be saying, okay, so we're at 8.8%. The national prevalence is 23%, and the PHN prevalence is sitting around 14%. Why is that? And I'd probably go back to my team and say, look, this is an interesting, deviation from perhaps where the rest of the country is and other practices. Just wanting to seek an understanding of why that's the case. Do you think we have less people with hypertension than other practices, or is it something about how we coding that and recording that? We could say the same thing about cardiovascular disease potentially as well when we look at this data. So I guess the way I'm kind of framing those questions, the important takeout is, we don't want to make judgments on the data. What we want to do is create insights from the data. And the way we create insights from the data is by looking at it and asking more questions of the data, and sort of going back to our teams, really. Now, some of the digital tools we have, like PenCat, have helped us to try and get our chronic condition registers right. So if we look at the next slide, what we've got in the next slide is, people with perhaps who could potentially have diabetes, but they're not on our system as having diabetes. So these are people, for example, on an anti-diabetic medication. So have we got somebody on that we're treating for diabetes, but we haven't actually coded as diabetes? Or is it because we've got, we correctly treat using that medication for completely other condition? So for example, metformin in women with polycystic ovaries is a perfectly legitimate use of that medication, which is normally used for diabetes. And we wouldn't expect to be coding that person. But, we can use the sort of data and look at other components of the data to see whether we've got our prevalence right or not, and then try and identify. So this is called case finding. So, in case management type of approach, we say case finding is important. And so what we're trying to do here is case find, it can and using the data to help us case find, so we can code people correctly. And if we've coded them correctly, they pop up on a register. If they pop up on a register, it means we can monitor their treatment, and we can make sure that they come into part of our clinical delivery system that's designed to meet their needs. So that's what we're really trying to do. So, just an open question. We won't spend too long on this one. But what other searches could you do to pick up those people with, who could have diabetes but haven't actually got that diagnosis? And any thoughts? So, the one example I gave you there was, are they on a diabetic medication but don't have a diagnosis? So that's one search you could do. What other searches could you do?
Well, maybe I can tell you that if I do my indicated diabetes with no diagnosis, I do find that if the doctors code pre-diabetic, that is not picked up by CAT4. So they're still staying in my list as patients that, that don't have might have indicated diabetes, but no diagnosis. So
Yeah.
I have to address that with PenCS, why that is, that doesn't get picked up, because not everybody is diabetic straight away. They might just have they're on the journey too. And with our patient cohort, if we're going up to Cape clinics, we have a high cohort of patients that are diabetics or become diabetics. And that's a bit tricky then to extract that back out of my CAT4 or my medical director we are working on. Yeah. So as for that question, I check if they had an HbA1c done in the last 12 months to see if we have a new reading. Some doctors say anything at 6.5 is still okay. Others might red flag that again. That depends, and it depends also, are the patients known to the doctors? And then, like you say, maybe they are on metformin, maybe we have patients that are obese and they are on Trulicity, or any drug that you can take for weight loss that are not related to diabetics, but they're still showing up in that list of indicated diabetes without diagnosis. So it's just a little brainstorm from me.
Great, thank you for sharing that. And then would your patients with pre-diabetes be coded as having pre-diabetes?
Yes, in medical director, they are coded as pre-diabetes. So I would have to search for those patients in medical director, but I cannot search for them in CAT4 because they are mingled in the list of indicated diabetes without diagnosis. Yeah. So that makes it a little hard. So I'm always hoping for improvement, which it's like everything, at some point, like I say, I wish there was no free text button. And then on the other hand, I wish there might be a button where it says, oh yeah, well, pre-diabetics, yes, how can I search them quicker instead of going always through the list and or just do the medical director patient search of no, I haven't, Janine. I haven't suggested that. You know why? Because it just comes to mind now. I'm getting old and sometimes forget. Maybe I should suggest that.
Yeah, you might have some success, because we have had some success putting forward some new observations and some new coded terms to use, particularly in practices that work with sports medicine, and they do some new technology. So SNOMED have actually added those into the library, which is then pushed out around, everywhere internationally to the software. So we do that through the Australian Digital Health Agency. So if there's anyone on the call that does find that their doctors are looking for a coded diagnosis and it's not there in the list or an observation, we can put it forward to SNOMED for consideration. So that's something to think about.
Yeah, because otherwise the doctors start hating me when I say go through the list, and they go, but I coded pre-diabetic, I did that.
Maybe I'll suggest it and see what it comes back with.
All right.
I think as a follow-up through on that is, the next question is, by having that code, is it going to make a meaningful difference? So if you could code your pre-diabetics, would that be a subpopulation for which you have a particular way of treating them that's different to perhaps the diabetic ones or the other ones? And my suspicion is you would, right? So that's an important distinction to make, and I think that increases the success of SNOMED adding it to the data dictionary. Okay, great. So thank you for that. Let's move on. So I think this is from the PHN. So this is a great checklist like you can use. So these are quality improvement activities that are already available to you through the PHN, which kind of take you through a structured process around how you can look at particular pieces of data and then what you can do with that data to build on. So this kind of helps break things up into little chunks that are manageable. And then if you work through the chunks, then you start to get towards a place where you're doing population health. So again, this is really there to encourage you to use the existing resources that are there, because they're really there to support you with the population health. And what we might do is, if we go to the next slide, Ange, we might actually invite Janine and team from the PHN to see if we can do a live demo of using the PenCat tool.
So those that are within the Anki PHN data program and within our region will have access to the Cat4 software to do your data reports. And some of you may be really familiar with this environment, so I won't spend too much time going through that. But what I thought, they've had a little bit of an update lately, so the interface is a little bit different. But generally, when you come into Cat, you'll see the demographic tree as the first screen. For some reason, mine's stuck on this refresh. What I generally advise users to do is ensure that they've got their active patient population filtered. And today we're going to look at the diagnosis report. And I'm just going to try and shift my screen across. So I want to go to the data cleansing tab, and I'm just going to try and find where I've put that now. There we go, data quality. Okay, so now we're in the Cat4, not the daily Cat. Thank you, Suzanne. You can see who uses it more than me. So we're looking at the data cleansing tab here, and along here it will have the tabs which has got the indicators and the diseases. So if we want to look at, say, CKD with no diagnosis, we want to look at those patients, and I'm seeing a de-identified, but in your practice you will see your patient names down the list here. And what we're looking for is anything that flashes red, these are patients that we recommend action, and that the disease is likely. And if it's orange, where the disease is possible, and if flags sort of yellow, well, they've sort of got them back to front here. It's sort of more of a beigey colour, pinky beige. Then we want to keep that in mind for review. And you can go across the different disease sets. So we can go from CKD to diabetes, and you see that we have quite a few patients that have the indicators, which I guess flag that they should possibly be coded as diabetics, but they aren't. So if we wanted to do a quality improvement activity to recall those patients to do a review, we could definitely pull them out of this list quite easily and identify them. And so it goes across. We've got mental health as well, COPD, osteoporosis as well across the top there. Is there any questions around that one?
No, not a question, Janine. I'm sorry.
That's okay.
Not a question, but you see, if I have that list, for instance, and at the right-hand side, even though I've got all the lovely ladies there now with my little text box, it says you can remove, exactly, confirm condition doesn't exist and remove.
Yes.
You know what I wish, that would go back to my medical software, because I can tick that there, that condition doesn't exist.
Right.
Will always come back up if it's not, you know, coded, or if the patient doesn't have diabetes, it always comes back with the next collect.
Oh, okay. So what would be useful as a user would be to recommend to Penn that links through to that patient record in Medical Director. Or,
Yes.
Yeah. And then you can update the diagnoses there.
Mm-hmm.
Yeah. Okay. Well, I can suggest that to them and see where it goes. But was there any other questions from anyone? There's a lot to take in on the screen. I'll stop sharing and hand back to you, Paresh.
Great, thanks, Janine. Okay, so I think what you were talking to Janine there is, you know, you can look at that data, and that data then generates some more questions for you, and then you can think about what you can do to improve that data. So again, this is a great tool that's available to you from the PHN around, you know, creating a work plan to help improve your data. I don't know, Janine, did you want to speak to this?
It's pretty straightforward, I think. So what we're trying to encourage is just to have a template for quality improvement in your practice, following that SMART goal mentality. And everyone's familiar with it. It's, you know, CQI is the buzzword of 2019, 2020, I think. So what we've tried to encourage here is just to have a template where you can remind yourself to measure, you know, the interventions, and to follow those steps at cleansing up your registers, and just to have that as part of your CQI activity portfolio. So it's available on our website through the Provider Hub 360, and we're slowly building the library of tools and templates that practices can make use of to support their PQI.
Great, thanks, Janine. And so what we're going to do is we're just going to move on to think about indicators, right? So we're looking at a lot of data here. There's different types of data. And so what we really want to think about is outcome indicators and process indicators. And without explaining them to begin with, I'm just going to throw it open to ask you the question around what process indicators or outcome indicators might there be, because depending on what you say, we'll use that as the conversation to try and dissect out what's the difference between the two and why have both. So let's just open that up. Any suggestions for what a process indicator is or what an outcome indicator is? You know, just tell me about indicators you might be using, whether you think it's a process one or an outcome one. Silence. Somebody earlier, I think might have been you, Suzanne, I'm not sure, but somebody earlier talked about, you know, you can look at the care plans you're doing or the home medicines reviews that are being done.
Yes, I was just tinkering around with that, Paresh, because I thought maybe I just don't understand this because I'm German. That's just, it's not my original tongue. But yes, so I would, if you say you need the process really to have an outcome afterwards. So if I would identify patients that are on multiple medications and see if they would benefit from a home meds review, you know, if I create this list and I contact the patients and see if they're interested. Some might not be, some are very keen. And, you know, as in my role, working for the Royal Flying Doctors, we do fly to multiple locations. We are working from Queensland health facilities, but we also have standalone clinics where we are visiting patients and go to community halls. and they see us maybe only once a month or every fortnight. So we have a good relationship with the patients, and you can engage them because, of course, if you only see a doctor once a month and you don't have facilities to drive out if it's wet season, or the next town is 300 k's away, there's a different relationship really for us with our patients than maybe in a standalone GP clinic in Brisbane or in Townsville or in Cairns as well. So we need to make sure that we provide care and, like you say, not reactive but proactive care, because if we keep our patients healthy and if our patients are healthy, the less retrievals we have to provide.
Yep, great. And you've beautifully identified I do proactive care there,
Yes.
which is great. So Suzanne, question, the research you do on people with, I don't know, 5 or more medications, or the people who have had a home medicines review, is that a process indicator or is it an outcome indicator?
Oh, now you get me. It's probably an outcome indicator.
Okay. What do others think?
What do you think? Well, it will be the outcome in the end, because it's not just the 5 or more meds, it's also beneficial for patients under 5 or more meds. It depends on the patient really, Raj, doesn't it? Because you might have patients that struggle already with 3 meds, and you say they would benefit from having a little, there you go, have a little process in place when to take their medicines. So, every patient has a different health literacy as well. So you can't just go by, okay, well, I just customize this 5 or more. You have to have a little bit of leeway.
Yeah.
So,
So Nicole's asking the question, is it a process indicator? And I think Nicolette, you're right. I would probably say it's a process indicator, because what we're really trying to do is, let's take a step back and, why are we identifying people with polypharmacy? Because the likelihood, well, there's a few things, isn't there? One is the risk of interactions is high. The high risk of interactions, which means they're more likely to have an adverse consequence as a result of their polypharmacy, which means they might end up in hospital as a result of that. And actually, if it's a very significant interaction or an adverse event, they might actually come to harm from it as well. So I would say looking at polypharmacy or the number of home medicines reviews done is a process indicator, because it's part of a process that wants to achieve an outcome, which is improving patient safety as a result of polypharmacy. So an outcome indicator for it, I'm not going to be cruel and ask you for what the outcome indicator might be, but I'll offer you some suggestions. So, some people would use hospitalization as an outcome indicator. I would actually say even hospitalization is closer to a process indicator. I think an outcome indicator would be the adverse event rate for people who are on polypharmacy. I think an outcome indicator would be a patient-reported survey around what they feel about their polypharmacy and side effects and burden of medication they're experiencing because of that. So why am I laboring this point? I'm laboring this point because often in healthcare, what we're trying to do is improve outcomes, but the data we often use is process data. And that's fine, because process data is easier to measure. It's more within our control. We just got to have a reasonable level of confidence that the process is going to lead to the desired outcome. In the fullness of time, when our computer systems and clinical systems get better, hopefully we'll start capturing those outcome indicators as well. So, in New South Wales, for example, as of couple of weeks ago, and I think I may have mentioned this last week, they rolled out a patient-reported measuring system across all health services in New South Wales, including general practices. So, that's an attempt by the health system to start to capture some outcomes data rather than sort of just process data. We need both, okay? And a lot of the data we'll be talking about will be process data. There may be some outcome indicators there we talk about. Often, even when we talk about the outcome indicators that we usually measure in general practice, they're more proxy outcome indicators. And so I'll kind of give you examples of that when we come to the relevant bit a little bit later on. So I'm actually going to just forgive us. We'll see if this video works.
And it's a lesson learned for us
on how to identify patients with outstanding diabetes cyclophonia items using a cross tabulation to make sure you only include those patients that didn't have the item billed already. So we do have, as always, our recipe online. You can go through there. It's showing you all the steps in screenshots, and you can download or even print it if you want. But this video will basically show you the same thing. So we're starting off in CAT. I want to calculate my filters in case you haven't done that. And of course, I have already my data loaded, which you might have to do. So normally you use the latest data you have available. I've just got the February data here, our demo data. So we've got the data loaded. Now, firstly, we need to apply a couple of filters. Under the Conditions tab, we want patients with diabetes. Clicking the yes on here will pick people with any type of diabetes. Just a side note, it does not include people with gestational diabetes, so you don't have to click anything there. And then under the date range result, because we're looking at a 12-month date range, 12-month period, particularly for the Medicare items here, clicking the 12 months on the date range result filter. That's the filters we need. Now you could, actually just going back there, you could consider only looking for active patients. But as you're probably aware, people with 3 visits in 2 years, that way you would exclude people that may have just moved to the area. They have diabetes, they've already had 2 visits, but they didn't have 3. So it's your call if you want to include this or not. I will leave it out for now. And recalculate, and you can see there are my 376 diabetics. So what we want to look at is the diabetes SIP item report. And you notice there are 3 tabs. We're interested in the third one, the items completed per patient. What it basically has done, it's pivoted the data around. So you can see there are 12 people that have all 14 items completed. And by the way, we report on 14 items. There are a number of other items that are part of the diabetes cycle of care, but we can't report on them through CAT. That's physical activity, self-care education, dietitian review, and also a medication review. So they are not included in the 14. The ones that we do include, you can have a look at the first tab here. The pathology, HbA1c, eye exam, BMIs, blood pressures, foot exam, cholesterol, other lipids, and a couple of other measures in here. So just be aware that this is not everything that you will have to complete, but it will tell you who did not have an item claimed and the ones with the outstanding ones. So we start right here. These are the 12 people with 14 items. We have 36 people with 13 items. We have another 50 with 12 items and 37 with 11 items completed. So we'll leave it at that. We've highlighted these 4 columns on the right. And we want to add another column now, and that's on the MBS item report. And we're interested in the not recorded, people that did not have a particular item recorded. In this case, it is the diabetes SIP here. So we have 252 people that did not have that item recorded in the last 12 months, because that's the filter we've applied. Now you've selected a column in here, little dot on the tab indicates that, and the little dot here indicates that we have other selections. To combine these two in a cross tabulation, you need to use the report button up at the top there. Clicking on that will combine these two, and you can see there are 35 people. All of these have in common that they have no diabetes SIP item claim in the last 12 months. and they have at least 10 of the items completed. So these would be your easy targets to complete a diabetes cycle of care, because they're nearly done basically. And you can, as always with this, export this list to Excel, PDF or Word. Thank you for your time.
Again, so when we're thinking about care plans and team care arrangements, the question is, are they outcome indicators or they're process indicators? Again, I would say they're an example of process indicators, but they're good process indicators to have, because if we get our care plans right, if we get our team care arrangements right, then we're setting up the platform to improve care for our patients. So again, I think it's a really useful indicator to have across the board. And you saw on that population health pyramid, and I kind of mapped it out for you last week, how those different segments of that population health pyramid align to the different GMS, MBS item numbers.
Sorry, Paresh.
Go on.
Quick question. So when we talked about the high performing primary healthcare and the 4 key sort of factors of high performing primary healthcare, we talked about the infrastructure one.
Mm-hmm.
So the top right box on that slide, would you say these types of process measures would fit within the infrastructure because they're around the way we do things within the practice? In terms of what we do, the processes, the workflows, whether or not we implement GPMP or TCAs.
Absolutely. So I think care planning kind of fits within that infrastructure part. And that's where the chronic care model fits as well. So again, hold that thought, because that's what we're going to do more of a deeper dive into next week. But maybe I could invite you, Janine, again to rather than us looking at a screenshot, if you could perhaps just take us through how to get this on PenCat.
Okay, so it's pretty straightforward, this one, and I know leads on nicely from those practices that receive our data reports monthly. There is an area towards the back of that document which highlights the eligibility for GPMP and TCAs that have been that haven't been claimed. This, you'll see a link, that other checklist document that we showed a little bit earlier will lead you on to this recipe, which will help you identify who those patients are. And of course, I'm working with de-identified data again, so we won't reveal any identifiable information here, but it's pretty straightforward. So you choose your filter, and you'll need to tick your patients are being active, and then head down to the tabs down below where it's got MBS eligibility, and then you'll see these 3 tabs pop up along here. So what we're wanting to look at in this demonstration is the GPMP and the team care arrangement eligibility, and to drill down and find out who those patients are based on the categories along the axes here. We just simply double click into that, and I don't know if that's going to show, but can you see that second screen on top of that screen? Yep. So it will then, list those patients, and if we've got a recall set up, we can actually just use this patients to feed into our recall process as well. So fairly straightforward, and a really quick way to identify what you may not be claiming. So we're sort of looking at that, not only the patient wellness, but also the business sustainability aspect as well. Any questions about that one?
No, that's great. Thanks, Janine. Any questions from participants?
So the next one, I might as well just show you this one as well. So this is in the standard reports area. So this is the Australian Primary Care Collaborative Report. So it basically looks at statistically your population of your practice and breaks it down by disease. So again, in the standard reports, and it'll look at your whole data set, so it'll clear any filters automatically. But it will go through and then just provide you an actual statistical count and a breakdown of population, which is quite interesting, and it actually puts a code based on the disease coding as well. So as you go down, you'll see you'll go through to diabetes, etc. So that's another interesting one as well, which we sort of don't see a lot of practices using this much, but I think if you really wanted to dig into population health, this is probably a good place to start. It's probably one we don't highlight enough in the work that we do. Any questions? Does anyone use this? Suzanne, do you use this in your practice?
Sorry, I had to find the unmute button first. No, I don't use it. I use all the other tabs, Janine.
Yeah,
I don't go by that one.
I think if you were starting out, this would probably be a good way to get really good oversight of the breakdown of the most prevalent disease groups and how to start working in that population health space. So yeah, there's so many in there.
Yeah, right.
I'll hand it back to you now, Paresh.
Thank you. Would you mind just doing your screen share again with that APCC report? Because I just wanted to pull out some learning there around process and outcome indicators.
Oh my God.
Great, thank you. So when you look at the APCC report, I actually really like this report. The reason I like it is it tells you the number of patients on your registers. It kind of gives you that sense of how, how accurate is our register, but also a sense of, because you've got the numbers there, if we've got 470 people on the CHD register, it gives you a sense of what your capacity needs are if you were to provide, care planning and GPMP and TCAs with the reviews and follow-ups for all of those. You can actually just map out what your capacity needs are. So that's one of the reasons I quite like this. The other thing I draw up is when you look at this data, it's got two sorts of data, right? So when you look at the indicators, it's got things like we've got the cholesterol recorded, and another indicator around the cholesterol is to a certain target range. So actually the cholesterol recorded is a process indicator. If we're not doing the process of care, if we're not doing the cycle of care, how on earth are we ever going to get to the outcome desired? Whether the cholesterol is to target or whether the HbA1c is to target and what target is to, it's more what we would call a proxy outcome indicator. So we know that if we get the HbA1c to a certain target, that actually then translates into less complications for patients with diabetes, reduced mortality, reduced end organ damage. So those things, the end organ damage, the mortality, they're your outcomes. That's what we're really looking to achieve. The HbA1c is just a proxy measure of that outcome, and whether we're actually checking the HbA1c is part of our process. So I quite like the APCC report because it pulls out both process stuff, but also proxy outcome measures as well. Great, thanks, Janine. Okay, so what we can move on to now is something around, so this is, the whole point of us wanting to do population health is then to improve care, right? So otherwise, why do it? We talked last week about gaps in care, and what we want to be doing is filling those gaps in care. And so what I'm presenting to you is some work done by, I think it was a Mayo Clinic who, when they first started looking at quality improvement, sort of came up with a process around how do you effectively get those care gaps in place. And so The next few slides are a little bit of theory, so I apologize for that, but the boxes at the bottom are giving you suggestions of what you can do and asking you questions to be thinking about and reflecting on. So firstly, we start with what's the evidence for the care we want to provide. So what's the evidence for treating diabetes? What are the bundles of care for diabetes look like? How often should we be doing foot checks and eye checks and HbA1cs and so on? Now, I'm going to make an assumption that we've actually got a degree of good evidence around that. Okay. We then think about what are the local barriers that's stopping us from achieving, that 100% care for all the things we've got the evidence about. And there's a whole bunch of factors that come together. And really our job, if we want to improve this, to get the population health outcomes we want, is to understand what those local barriers are. And so that often involves talking to staff, talking to doctors, what they call walking the process. So what we want to do is, if I were a diabetic patient coming through the practice and I walk through the practice's process, will it meet my needs? Where are the gaps in care? Where are the defects in our practice process which would stop it meeting my needs? We really want to engage all the stakeholders. And by stakeholders, I mean internal stakeholders. It could be your GPs, it could be your dietitians, diabetes educators that come in, but it could be people you refer to as well, maybe even the main pharmacy your patients go to. Or we really want to engage them and really get their kind of sense around what we're trying to achieve and why we're not getting there yet. So that's really the first step. And the way we can do that is through observation and dialogue and looking at metrics, often process metrics. We can think about what good looks like and we can think about what bad looks like. Because of time, I'm not going to dwell on this, but it's really trying to just stimulate your thinking around how to approach this. We then go on to think about, okay, so we've got to measure performance, right? And we've had this whole conversation around what measures we use. Are there process measures or are there outcome measures? What we want to do is actually identify a battery of measures that will give us a good sense of how things are doing. And so in order to do that, we might actually develop and pilot some test measures. So, that earlier example we had around people with mental health problems, we haven't necessarily got an indicator for that. So what indicator will we use? How will we pilot it? And then we want to really get some baseline data. So if we look at the box at the bottom here, we're selecting measures. We actually want to be doing PDSAs on that, are we getting the measures right? And what we want to do is get a really good baseline. Now, an interesting statistical fact is you need about 12 to 15 data points to understand what the variation in your processes are like. So if we're measuring monthly, it will take us 12 to 15 months to just get to know what our baseline is. So should we be measuring a bit more frequently, particularly if we're proactively working on things? Food for thought. I'll leave that as an open question for you to think about. And once we've done that, we then go on to this cycle on the right-hand side. Okay, so the first thing we want to do is to engage with people. We want to explain to people why the intervention is important. And this could include our doctors, our nurses, our allied health, but also our patients. And then the question we have to ask ourselves is, if we have to engage with them, how will we engage with them? And again, this is just to stimulate your thinking and your thoughts, really. Where along the engagement spectrum do you need to be? Do you need to be giving them information and saying this is what we're doing? Or do you need to be at the other end where you're actually co-designing with them. The EBCD stands for experience-based co-design. So are you actually co-designing things with them? So it's really at what stage of that engagement process do you want to be at? What's important is engagement happens, but you've got to work out how granular you want that to be. And then we move on to education. So we can, you know, I kind of often say to people, education is necessary, but never sufficient. So yeah, we've absolutely got to educate people. We've got to share the evidence, you know, support the intervention. But it's never going to get us to a point where, you know, we're delivering optimal care. So by all means, educate, share the evidence, look at how other people are doing it to learn from others, you know, maybe even go to other sites and have a look at them to see how they're doing it. But actually where it starts to make a difference over and above education is the execution part. Okay, so the execution part is really around looking at a whole bunch of stuff. It's looking at those barriers you identify earlier, and turning those barriers into enablers. It's often about standardizations. It's often about how do you get everyone on the same page and work together, so they're doing things in the same way.
And that's about changing the workflow and also the behaviours attached to the workflow.
Yep. It's about sort of independent checks. It's about individual feedback. It's about having good reminders and recalls in the system. And it's about learning from mistakes. So let's use reflection and learn from when something doesn't go the way it should to see how we can improve it. There's a whole bunch of quality improvement tools out there and thinking out there, you know, things like driver diagrams. There's something called the London Protocol, which helps us better understand why things aren't happening the way they should be. There's a whole bunch of thinking around violations and migrations, which is why, you know, thinking about why we often don't stick to policy and procedures. So we might have a policy that says do this, but we often don't stick to that. And that's actually the human factor, right? It's human nature. So how do we just accept the human nature and redesign our processes to think about that? So that's kind of comes into this concept around reliability and reliable health systems design. So it's a whole bunch of learning we can do around that, which can inform this execution piece. And of course, once we've done the execution piece, we've got to evaluate. We've got to keep looking at things regularly, you know, to assess and track how we're going, right? So, and here's the questions we've got to ask ourselves, you know, how often will we measure the indicators, you know? Are we going to measure them monthly? Bearing in mind what I said about the baseline earlier, are we going to begin with measure them weekly? And once things stabilize and we're getting to where we want to be, then go to monthly. What things are we going to measure? Are we going to measure mostly outcome stuff? Or are we going to focus more on the process stuff because that's easier to measure? Are we going to measure any unintended consequences of the changes we're making? That's what balancing measures are. So that's a really quick run through an approach which helps you think about getting reliable quality improvement into practice, I guess, and making that a sort of structured, systematic process. And again, come back to the data improvement work plan from the PHN. I know we've talked about this earlier, but I've put it in here again, just as a reminder to say, actually, what you've got in this data improvement work plan and the way the PHN's put this together is some of that thinking already embedded into the framework. So, you know, if you use the improvement work plan with the fidelity it's designed with, then it should actually build some of those elements in. So we'll just crack on, because what we really need to now be thinking about is, again, if you look at those building blocks, sitting under population health was enrollment, patient registration, empanelment, whatever you want to call it. And so we're going to just move on to this kind of concept and why it's important, because this is where the accountability part of things start to come into the equation. So, registration is really this kind of act of registering individual patients with the practice, right? So it's at a practice level. And if we do get this happening as a system, it's going to be voluntary. But whether it happens or not with the policy reforms is something we can think about doing in our own practices, because it supports population health. Now, if we're a small practice, registration and with the practice and registering with the panel might be exactly the same thing. But if we're a big practice, if we're a practice of 20 GPs, let's say, registering with the practice is different to registering with a panel, because it's hard to create accountability amongst 20 different clinicians. But if you can break those clinicians into smaller groupings, and those groupings can then become sort of accountable for specific populations, then you get that same concept running through.
Yeah, and this then that fourth building block, which is around that team-based care.
Absolutely.
So you can see how one building block builds on another building block, and how it all cascades up through that high-performing health system.
So if we look at the next slide, what the next slide tells us is, kind of introduces this concept of panel arrangements. And what it's saying is actually, if we've identified those subpopulations we talked about right at the beginning, those subpopulations need to be assigned as a panel to a clinical team. That clinical team could be the GP and nurse. It could be 2 GPs, a nurse, and an allied health team. That's up to practices to work out individually. The takeout is, what we really want to do is assign patients, subpopulations that have similar clinical need to a panel, and that panel is then responsible for caring for them to ensure that those needs that we've identified are being met. And so if we then move on to that next step, which is around, can we break up all this data we looked at earlier and into sort of chunks that are around a panel? And so again, I'm going to hand over to Janine to see if you can do a demo for us, Janine, around breast cancer screening, which is what this slide's sort of showing us. And then can we break that up and dissect it down to GP level?
Sure. So everyone should be able to see my screen. So what I've done at the top in the filter, just ensure that we've obviously we're looking at mammograms and screening. So we want our female population. I've started at the age of 40, so I've added that figure in there. I've ensured that we've got the active population. But if we want to look at empanelment with a provider, we also need to come and have a look at, ticking and filtering by the provider. Okay, so we want to look at what patients are assigned to a particular provider. So in your view, you would have your doctor's names here. However, I've just got some bogus ones. And then come down to the bottom filter area, and we're looking for the screening tab. And then we want to look at, the breakdown of the data. So we would potentially be wanting to recall those 216 patients that are assigned to that provider, or we may have more than one provider up here as well ticked. And then we would simply double click on that, and that would open up the list, which we could then, if we were part of our cancer CQI project, you would have access to the GoShare Plus bundle and a campaign and SMS campaign around that, which would enable you then to send some targeted content bundles around mammograms and preventative care directly to those patients. Has anyone utilised those bundles yet? Anyone on the call who's part of that CQI project? I'd be interested to know.
We have just received our SMS credits, so we will utilise them very shortly, Janine.
Great. It'll be awesome to work with you to track the engagement rates on that, Suzanne, once you start doing that. So that's pretty much it. So it's pretty straightforward. Is there any questions? Sorry, I was showing you cervical. It was meant to be mammogram. So that was cervical I was showing you, just realised. And then we've got bowel as well. So but this obviously is still set up for the female filters. Yeah, so you can play around with all of those filters. It's quite informative and quite an easy way to extract those impaneled, I guess, patients. An interesting thought that I've been having is how are we going to do this with COVID vaccinations? Not necessarily empanelment back to a particular provider, but how are we going to know in practice which patients are coming through our doors that aren't our regular patients and which are just coming to be immunised, and how we're going to keep that separate, because there's all kind of impacts around our standard whole patient equivalent numbers and how we you know, how our practice incentive payments are organised through that. So that'll be an interesting space to watch, I think.
Absolutely. Thanks, Janine. So that kind of gives you an example, you know, a way of looking at data, and then, you know, by the provider, and so you can look at whether that panel is achieving what it's trying to achieve. And so if we look at the sort of next slide, so this was really just showing, and then, you know, when you get these panel reports, like Janine was showing, you can then sort of, you know, as a panel, so in our practice, what we do is we have a huddle process, and so we huddle with we have patient advocates. We kind of huddle with them, and we'll look at this panel reports and say, oh yeah, you know, Mrs. Smith and Mr. Brown and Mr. Singh there, you know, we need to do A, B, and C with them. And so that's how we kind of realize some of the population health approaches in our practice. So we use the panel reports in a very operational way to then think about what we're going to do and manage patients.
And when it comes to part-time workers, for example, if you're in a large practice, the ability to group your part-time staff together in one micro team responsible for one panel means that this shared accountability is held within the team, but the continuity of care still is delivered to the patient.
So we've done a bit of a run through looking at data. You know, a lot of our focus so far has been on condition specific data. And the conversation we had last week, and I was kind of implied earlier today, is do we need to sort of move in a direction which is more around needs-based care? So it doesn't matter whether you got COPD or diabetes or ischemic heart disease. What are your needs? And then how do we best meet those needs in the care we provide? And so depending on where you are in your practice and your journey of sort of quality improvement, if you've been doing it for quite a while, actually the next step might be to think about looking at that population pyramid and mapping your patients to the population pyramid and using a needs-based approach. So how do you do that? So one of the ways you can do that is to identify your population with multimorbidity. So again, PenCat has reports which help you identify, patients with just one condition. That group might be in that lower layer of that population pyramid. And as we start to get people with 2 conditions, 3 conditions, 4 conditions, we start moving up that pyramid layer, because, we don't necessarily want to be case conferencing for everyone with 1 condition, but case conferencing for people with 4 conditions, which is a much smaller number, is manageable, and we're more likely to deliver impactful outcomes for that group. So it's about how we tailor the care we provide based on the needs as well.
And if we think about rise and risk patients, Paresh, so patients with 2 or 3 conditions that could potentially fit in Kaiser Permanente's care coordination section. So the introduction of care coordination for them might actually reduce their risk, enhance their self-management capability to actually, and their better health outcomes on the back of it. So the quadruple aim in effect.
So, if we keep thinking around this needs-based thinking, within PenCat, there are tools and points you can go to that allow you to sort of better identify comorbidities. So this is just another example of a report from PenCat. But if we move on to the next slide, what we start to actually see is, health systems becoming more sophisticated with the way they stratify their population and their risk. So this is a slide that comes from the Agency for Clinical Innovation in New South Wales. And what it's doing is it's using some of that data, that PenCat data around how many conditions people have. It's combining that data with how many medications they're on and also their age, depending on whether they're Indigenous or non-Indigenous, and then pulling together based on a combination, a composite of all that information, a risk. And then the management of patients based on their risk is then tailored. So if someone's high risk, they'll have a different intervention to someone who's medium risk. So this is where the system's going. And I guess in general practice, we will eventually collectively sort of get to that point. We're at a much earlier stage in most practices at the moment, but I think it's important for us to know where the destination is, which is why we've kind of included this in the presentation. And again, I might just pause here at the next slide, which is really asking you for your reflections and your thoughts. So again, hand over to you. Any reflections, any thoughts around this?
Again, feel free to unmute yourself or else use the chat box if you want to add a comment.
Paresh, it's Janine here. As a GP, how do you feel patients feel about empanelment? Do you think that, I guess if it's a chronic disease patient, they're probably very comfortable with their regular GP, but you do have to treat a lot of people that just aren't your regular active population as well. I'm just, thinking through the practicalities of empanelment and when it becomes, I guess, cost effective and good in terms of patient care.
Can I answer that from a patient perspective?
Sure.
I've very recently moved practice. So I've moved from a practice that didn't have empanelment to a practice that does have empanelment. And my experience of both the onboarding, the establishment of a relationship with a GP who I know is going to look out for me and look after all of my needs, distinct and different from part of my needs, and who I will be able to have a very open and frank dialogue with, and who I have already experienced sort of 1 month in, proactive care as opposed to reactive care. So I'm probably looking at this from an informed perspective around processes and what higher performing primary health care looks like. But from my perspective, as someone who's very recently been through a healthcare episode, I have got more confidence in both the practitioner, but also the practice to look after me and to work with me to better address my health needs. And that's a very recent experience that I've been through. So that's from a consumer's point of view, but I do caveat that with obviously an understanding of what high performing primary healthcare looks like. But from the practice point of view, Paresh.
So I think it's a bit of a journey, Janine, and I think as a practice and as a GP, when you sort of get to a mature stage of that journey, empanelment actually makes my life easier as a GP, and it improves my professional satisfaction, because what it allows me to do is know the people I'm responsible for, be supported by a team in looking after those people, and gives me the confidence that the goals of care are really being met, and actually gives me the confidence that things are safe. So I'll give you an example which has really come up this morning. I do a lot of aged care work, and so the whole issue of patients on psychotropics and the safety of that is a clear issue. And based on the Aged Care Royal Commission report published on Monday, it's going to be a topical issue, right? And whether as GPs we're going to be allowed to continue to prescribe psychotropics or not. But what happened like this morning was working with my extended team. So this isn't employed members of the team, but people outside the practice, so within the facility and the pharmacist, is, we talked about how can you do this proactively. So we created a register of patients who are on psychotropics. So that's a working register that we'll work to. We've talked about interventions that are required around managing those patients and the care planning aspects. And actually, in order to manage those patients on psychotropics, particularly for behavioral symptoms of dementia, as a prescriber, I actually have limited options open to me. The bigger options are really with the facility and the training of the staff and the care planning around that. So what we've actually done is said, we're going to have a register. We've identified the evidence of interventions that help. We're going to create a proactive, structured approach to reviewing these people on a regular basis. So we've looked at how many people are on the register. So we looked at the capacity issues. We've worked out that we need to look at 7 patients a week to get a 13-week cycle of them being reviewed. And we've looked at how we're going to do that. So we're going to do that as case conferencing with the pharmacist, with the RN and myself there. We're going to set aside an hour a week to talk through those. And then coming off the case conferencing will be a GP contribution to the care plan, which talks about the medication and plan with the medication, whether it's a reduction plan or keeping them on the same dose, whatever it may be, together with a behavioral management plan, which the facility can then act on. And then on a 3-monthly cycle, we keep this case conferencing going and review and monitor. Does that help, Janine? Does that answer your question?
Yeah, I think you've both provided some really insightful examples. And I think what empanelment means to me is being able to plan effectively and resource your practice to ensure that you're proactive in that patient care. So you can definitely see the as both of you have delivered those examples, it's very clear that there's some very good advantages if you can get to that point where you are in using empanelment in your practices, I think.
And I think another aspect to remember around empanelment, relating to the quadruple aim, is around that fourth aim, which is around the joy of work. So as you can see, obviously the proactivity increase and the health outcomes of patients increase, and your relationship with those patients increase, their self-management capability increase. I would suspect the joy of work in that fourth aim the results would be a lot higher there, and it would be more satisfying for people working within the practice to operate within that environment.
Great, thank you.
Great. So what we'll do is we're at the tail end and we're running a little late, so forgive me, we might overrun by a few minutes. So if we're going to do population management, and we've talked a whole load today about the use of data in that, what we need to really do is identify tasks and responsibilities around who's going to do what and what those functions and tasks are in order for us to do population health. So what this slide is really telling us is, is defining what population management is. And it's telling us that in order for us to be able to do this, we need to have those registers, and we need to be able to create reports from those registers by subpopulation and by evidence-based guidelines. So, for me, in my practice, it's not good enough to have a registry report that lists all my dementia patients or patients with dementia. I need to have a report that lists my patients who have dementia who are also on psychotropics or who are also on, diabetic medications as 2 different reports. So it's creating that sort of subpopulation because, arguably my patients with advanced dementia who have diabetes, my targets for their HbA1c are going to be different to maybe younger patients who don't have dementia. And so using the same way to manage both of them isn't fit for purpose. We need to manage the 2 in different ways and report on them separately. It requires us to sort of make the data visible, because it then helps us to hardwire that in the way we do business and business as usual. It's not about one-point data, it's not about snapshots, it's about trends. And for trends, we need repeated measurement. And then, we need a function within the management of population health around somebody who can support the clinic, the GP, around coordinating referrals and sort of care management, depending on where they are on that population pyramid. Now, if we move on to the next slide, we talk about panel management. And panel management and population management, like I said earlier, may be the same thing, depending on the practice, but it may be different as well, depending on how big the practice is. So panel management is more that accountability piece, right? So in the example I was giving about patients with dementia who are on psychotropics, I need a report for my panel, the people I look after, at a practice level, we might have a broader report, which is really, patients with dementia on psychotropics, but that doesn't sort of mean much to me unless I put it broken down to the patients that I'm responsible for. So that's the key difference, I guess, between population management and panel management is the accountability. The slightly additional functions when you're looking at a panel management approach is also, keeping that list up to date. So I've had 3 patients pass away sadly this week. I need to inform my team so we can make sure that they come off the system and are marked as deceased, so they then continue to feature in our data going forwards. When people move in and out of the system, we need to sort of be facilitating their transitions and their medicines reconciliation, for example. So it's important to think about population management and panel management, what the roles and tasks are. And on the next slide, what you've got a matrix which lists the different tasks that are required for population management and panel management. And at a practice level, you can work out who's the best person, what's the best role to undertake those functions and tasks. So this is, again, part of that engagement piece we talked about earlier. You can engage the whole team in looking at this.
And I think a useful starting point is to ask, who does this now?
Yeah.
Because most of this already happens within the general practice.
So I guess as we come to the final couple of minutes, what we wanted to do today was describe how we use our digital systems to support population health. And so we really looked at PenCat as a tool which allows us to slice and dice our data into meaningful subpopulations. Once we've got those meaningful subpopulations, we can look at the process indicators and we can look at the outcome indicators for those subpopulations and ask meaningful questions. Why have we got less people with hypertension than other practices in the region and in the country? And maybe we can then say, all right, well, it may be because we're not coding our people with hypertension. So how can we interrogate the clinical information system to identify the ones who we're not coding? Can we do the search? Can we do a search on people not coded as having hypertension, but are on blood pressure tablets? Will that help us identify some of that missing populations, help us with that case finding? And in essence, that's really what we talked about today with the intelligent use of data to drive improvements.
One of the results from asking those questions, maybe, Paresh, one of the insights and learnings, maybe, well, actually, our practice population is distinct and different from other general practices, and we are servicing our patient cohort, our population appropriately. It's just the fact that we've got a different mix within our practice.
Yeah.
And that's a valid result. And if you're ever questioned in terms of why you are perceived to be an outlier in relation to the PHN or nationally, your response is, well, actually, our patient cohort is different. We have different needs within our practice that we service, but we're doing that appropriately within our practice.
So I'm going to leave you with some questions, all right? Because this is the so what bit, okay, which kind of comes on the next slide as well. But what data do you need to collect that you do not collect or engage with now? So what are your additional data requirements? How could you better organize preventative and chronic care within your practice to meet the needs of your practice population and ensure there are minimal care gaps, right? So that's planting a seed for next week's presentation. And what systems and processes do you have in place to let the rest of the team know when routine or preventative care is due? over and above the reminders you might get in best practice or medical director. And with that, we'll just remind you of that reflective template. So, we've talked a lot today. Hopefully we've provoked some new ideas and thinking. The question for you is, so what does that mean for you in your, for you as an individual and for your practice? And what are you now going to do as a result of that understanding? So really, really, if you do nothing else, really encourage you to look at this reflective template and ask yourself the so what question and the now what question, because that's what's going to make a difference to your patients as a result of any learning you've taken away today. Thank you for your time. Our contact details are on the screen. Did you want to add anything?
No, I'd just like to think that I learned something new from every one of these that we deliver. So thank you for your participation. We hope that you've learned too, and feel free to provide your feedback.